I'm going to now invite, I've got to pronounce it correctly. Is it Dr. Biase? Is that correct? D. Biase from, he's obviously Italian. That's the good part of it. He's an electrophysiologist. That's not a good part of it. But I'm just joking. He was actually worked several years with Dr. Natalia. I understand he was in Cleveland Clinic, then he was in Texas, and now he's seen the light of the day and he's gone to New York.
Yes, for some time. Thank you. I would like to thank the organizer for the invitation, Dr. Lucky Reddy in particular, which has been organizing all this together with Dr. Natale and all the other organizers. So systemic thromboembolization, the role of the left atrial appendage, these are my disclosures. And, you know, maybe we are almost at the end, so many of the information that I will tell you, we have already gone through. Let's try to make it a little bit lighter presentation. Atrial fibrillation is a substantial cause of morbidity and mortality, increasing the risk of stroke, other embolic complication, congestive heart failure, and death. And we all know that there is a projected number of increasing patients affected by atrial fibrillation. We also know that atrial fibrillation and age are correlated. So we live more, so more patients have atrial fibrillation. So this is a pandemic for everybody of us. And we know that atrial fibrillation increased 4 to 5 times fold the risk of stroke, double the risk of dementia, and tripling the risk of heart failure, 40 to 9% increased risk of overall mortality, and the risk of stroke in atrial fibrillation patient is related to age, 1.5% in this 50 to 59 years of age, 23.5 when you are older. So the older are the patients with the higher risk. And this is just a way to summarize this concept and the correlation between age and atrial fibrillation. So we live more patients will be affected by this problem. We also know that the management of atrial fibrillation is ventricular control rate or rhythm control rate. And of course, we do the ablation, we like rhythm control, but in both arms, thromboembolic prevention is the key, is always there if you choose one or the other. And we know that the stroke risk in atrial fibrillation, again, is related to age. We have clarified this. We also know that the major cause of stroke in patients with atrial fibrillation is the presence of thrombus into the left atrial appendage. So how to understand which are the patients that are at higher risk of developing a stroke? Several scores have been tested. The first one was the CHATS score. Why? We have patients at high risk factors like mitral stenosis, prosthetic heart valve, a previous history of TIA, stroke, age, hypertension, diabetes, and less validated risk factors or dubious factors like duration of atrial fibrillation, pattern. Anyway, identifying which are the patients that are at risk of stroke, it's our question. And this is the CHART score, which everybody know. We have 1 point, 2 points, 3 points. If you have a previous TIA stroke, you got 2 points. But still, this score is very good, but was not enough to predict which patient were having a stroke, because even patients with CHART score 0 or 1 were having stroke. So from this score, also, it's important to realize that the guidelines tell us that when the CHART score is 0 or 1, aspirin or INR is depending on our clinical decision making. So guidelines are not telling us what we should do. So we still have an area where we don't know, and as well as anticoagulation, the same should apply for closure device. We don't know in this area if we should put a closure device or not. So in this area, we still have to identify patients. Then we have the CHAT2VAS score, which is a little bit more complicated, but just try to identify more patients that are at risk of score. But even this score has some issues, and we still have patients with low CHAT2VAS score that have stroke. So the problem is not solved, and we need to find something else. So we try to put our attention on the left atrial appendage, and this is the first study that is in the literature describing autopsy in 500 patients. This paper was published in 1997. As you can see, in this patient, they start looking at the morphology of the appendage, but in an early era they were not utilizing complex imaging technologies, and they were looking at the autopsies, and they found some differences in between sex, in between the size of the orifice, in between age. Several differences were found. So from this preliminary study, and as you can see here, 2 lobes of the appendage were found in 54%, although the definition of lobes is different from the one that we will apply, because these were lobes considered, even if this may be considered the primary lobe. So this was an initial definition of the lobes. First study that I found that where there was a correlation between the left atrial appendage dimensions and the stroke is this from the group of Dr. Mansoon and Dr. Raskin. Here they try to find left atrial appendage depth or the left atrial appendage neck as predictor or correlated with stroke, but this correlation was okay, but was not perfect. In fact, the left atrial appendage dimension strokes in patients with atrial fibrillation assessment by MRI was an adjunctive for that, but was not excellent. Why? Because during atrial fibrillation, the left atrium goes into remodeling, so the dimension of the base of the appendage, of the neck of the appendage, may modify over time. And they also tried to look at the appendage morphology by intracardiac echo, as you can see here, but the fact that eyes has 2 views, has not 3 views, was not able to differentiate several types of appendages, although eyes was very good in predicting the ostium, diameter, and other parameters like the width or the length of the left atrial appendage. So starting from here and from another study that we did where we tried to identify morphology as the predictor of TIA stroke, we did a study where we classified the appendage in 4 different types, and this was utilized to plan the closure device placement. In this study instead, what we did, we correlated this morphology that we tried to assess with the history of TIA stroke. So the aim of our study was to identify different left atrial appendage by CT of MRI to categorize different LAA morphology and the correlation with TIA stroke. So the study population consisted of 932 patients. All patients underwent CT or MRI, and all patients were screened from history of TIA stroke. So we utilize CT and MRI. I'm not going through the technique utilizing to identify this morphology, but 4 morphologies were identified: the cactus, the chicken wing, the windsock, and the cauliflower. I'm not going through the definition because many other presenters have already gone through this morphology. I'm just showing you the differences between CT, which is more defined in giving us resolution about the morphologies, and the MRI on your right here. So they look the same. There was inter-agreement statistical validity in identifying this different structure between CT and MRI. So this is the cactus morphology that we identified. This is the chicken wing morphology that we identify with CT again on the left side and MRI on the right side. This is the windsock morphology, and this is the cauliflower morphology. So we did some statistical analysis, and again also a kappa test to assess inter-agreement validity of the study. Several statistical analyses were done. As you can see, no statistically significant bias was noted in classifying the morphology by the operators using CT and MRI. These were the baseline characteristics, but I want to go to this slide, which is the most important. So after controlling from CHA2 score and CHA2-VASc score, and gender and AF type, non-chicken wing morphology was found to have prior TIA stroke with an estimate of 2.95. When compared to chicken wing, cactus had 4 times, windsock 5 times, and cauliflower 8 times more likely to have prior TIA stroke. So all morphology that were not chicken wing had a higher risk of TIA stroke. And more importantly, in this slide, non-chicken wing was found to be an independent predictor of stroke, as you can see here in the overall population. But when we sort this in between patients with a CHA score 0 to 1, the validity of the study was still there. So it's important to know that in the CHA score 0-1, we don't know which is the anticoagulation management that should be utilized. Is left to the clinicians. So with this added information, I would say that if I have a patient with a CHA score 0-1, I will look at his appendage morphology, and if it is non-chicken wing, I would suggest a more aggressive anticoagulation or closure device management. And another important thing is that a chicken wing morphology was present in our study in 48% of the population, which overlap what was found in the circulation paper of 96, where the 2 lobes were in 52% of the patients. But you can say, oh, this is your study, nobody has replicated this. I would like to show you what doing autopsy for other reasons. This is the Anatolian Journal of Cardiology. It's a paper in press in Turkey. As you can see, this is a real anatomy of a patient that died, and this is a chicken wing morphology, and this is the highlight. As you can see, it's very similar to our chicken wing morphology identified by CT and MRI. This is our windsock morphology. This is what was found in the heart of this patient. As you can see, there is a real anatomical similarity in between. And again, this is what we called cauliflower, and this is what was found in this autopsy here. As you can see, very similar to what. So imaging is key in this scenario. And this is the cactus morphology that was also identified. Also, another group recently, this is another IMPRESS article in the Heart Rhythm Journal. They classified the cactus, cauliflower, chicken wing, windsock. They found cauliflower as to be more associated with the TIA stroke, although, again, also in this study, non-chicken wing morphology was associated with a higher risk of stroke, although their definition of morphology was not as clear as in our study. This was cactus, this was cauliflower, this was chicken wing, and this was windsock in their study. And these were the methodology utilized in 80 patients. The left atrial appendage anatomy was classified, as I told you, and again, they found in the results that that cauliflower was associated with a higher risk of TIA stroke, even when the CHA2-VASc score was adjusted, although by looking into the data, non-chicken wing was associated with a higher risk of TIA stroke versus chicken wing. Of course, the study, as our study, have some limitation. The number of stroke patients was small, although if considering our study and this study is not that small, and this study has a major limitation of being retrospective, as our study as well. We don't have a randomized study for this, and the timing of the echocardiographic studies and CT evaluation varied in between patients. They concluded that the left atrial appendage anatomy might be useful for predicting strokes in non-valvular atrial fibrillation patients with low CHA score. So we have published a paper. This paper has been replicated. The anatomy of the necropsy looks like the same morphology that we showed before. So I would like to conclude that all these studies suggest that in patients with the chicken wing morphology are less likely to have an embolic event even after controlling for comorbidities. If confirmed by a randomized study, these results could have relevant impact on the anticoagulation and occlusion device management of patients with an intermediate risk for stroke. Thank you very much for your attention.